Welcome back to the deep dive. Today, we're tackling something really crucial, especially if you've got exams like the MSRA on your horizon. Adult Advanced Life Support Guidelines, ALS.
Exactly. We know it can seem complex, so we're aiming to cut through that. We'll focus on the core stuff, the really high-yield principles you absolutely need to know.
Yeah, trying to make it clear, concise, and hopefully stick in your memory. So, we're looking at the ALS guidelines, particularly that big split shockable versus non-shockable rhythms.
That's the plan. Provide a solid framework you can recall, even under pressure.
Okay, let's dive right in. Cardiac arrest scenario. First big decision point is the rhythm, right? The guidelines break it down neatly.
They do. Two main buckets,
Yeah.
shockable and non-shockable.
So shockable first. What falls into that category?
That's your ventricular fibrillation VF and your pulseless ventricular tachycardia pulseless VT. Think of it like electrical chaos in the heart. Needs a shock to try and reset it.
Okay, VF and pulseless VT.
Yeah.
Shockable. And the other side, non-shockable.
That's asystole, the flatline, and pulseless electrical activity, or PEA. With PEA, you might see electrical complexes on the monitor, but there's no actual pulse, no effective heartbeat.
Right. So electricity is present, but not doing the job.
Precisely. Maybe a quick memory tip. For exams, shockable VFET, think electricity might help. Non-shockable asystole PEA, a shock alone won't fix the underlying issue. Something else is wrong.
That makes sense. Electricity for the electrical chaos. Got it. Now, whatever the rhythm, compressions are fundamental, aren't they?
Absolutely non-negotiable. High-quality chest compressions. The standard is that 30 compressions to 2 breaths ratio.
And the really key point, keep them going.
Yes. Keep compressing even while the defibrillator is charging up. Minimize those pauses. Every second without flow counts. Any interruption is bad news for perfusion.
Okay, minimize interruptions. So let's talk defibrillation itself. For the shockable ones, VFVT, how does that work?
Generally, it's a single shock strategy. You deliver one shock, then immediately go back to 2 minutes of CPR. No pulse check straight away, just CPR.
Just straight back on the chest. Is there an exception?
There is, yeah. A specific one. If the arrest is witnessed and the patient is already monitored, think CCU, ITU, maybe cath lab, you might consider stacked shocks. That's delivering up to 3 shocks in quick succession before starting CPR, but only in that very specific controlled setting.
Okay, so single shock, usually. Stacked shocks, very rarely in specific monitored situations.
Yeah.
What about the energy levels for the shocks?
Good question. If you're using an older monophasic defibrillator, it's 360 joules right from the start.
Okay.
But most places use biphasic now. For the first shock, it's typically somewhere between 150 and 200 joules, depending on the manufacturer's recommendation.
And if that doesn't work, subsequent shocks.
For later shocks with a biphasic machine, you generally escalate the energy, often up towards the maximum the device allows, which could be up to 360 joules, again, depending on the specific device.
Right. Escalate the biphasic dose.
Okay.
That covers the electricity. What about drugs? How do we get them in during ALS?
Well, the best route is intravenous, IV access. That's the gold standard.
But sometimes that's hard, right?
It can be, definitely. If IV access is difficult or delayed, the intraosseous route IO is a fantastic alternative. You're essentially injecting directly into the bone marrow cavity, which gets drugs into the circulation very quickly.
IO is a key backup. Is there anything we shouldn't do?
Yeah, one thing that's definitely out now is giving drugs down the endotracheal tube. It used to be done, but absorption is just too unreliable. So IV or IO, no ET route for drugs.
Okay, IV or IO. Got it. Now, adrenaline, big one in ALS.
Right.
When does it come in?
The timing is crucial and depends entirely on that initial rhythm. For the non-shockable rhythms, asystole and PEA, you give 1 milligram of adrenaline as soon as possible. Get it in early.
ASAP for non-shockable.
Yeah.
And for shockable, VFVT.
For VFVT, you hold off initially. The adrenaline, 1 milligram again, comes after the third shock has been delivered and hasn't worked.
After shock number 3.
Okay.
And then repeat doses.
Yes. Regardless of the rhythm, if the arrest continues, you repeat the 1 milligram adrenaline dose every 3 to 5 minutes, basically during alternate CPR cycles.
Every 3 to 5 minutes. Yeah. What about other drugs? Amiodarone often comes up.
It does. Amiodarone is an antiarrhythmic specifically for refractory or persistent shockable rhythms. So VF or pulseless VT that hasn't responded to shocks.
And the dose?
The first dose is 300 milligrams given after that third unsuccessful shock.
Same point as the first adrenaline dose in VFVT then.
Exactly. And if the VFVT persists even after more shocks, A second dose of 150 milligrams can be given after the fifth shock.
300 milligrams after the third, 150 milligrams after the fifth. Is there an alternative if amiodarone isn't available?
Yes, lidocaine can be considered if amiodarone isn't an option. Same situation, persistent VFET.
Okay, good to know there's an alternative. This is all great detail, but let's rewind a bit. Before algorithms and drugs, that initial assessment is paramount, isn't it?
Oh, absolutely critical. First thing, always, check for danger. Ensure the scene is safe for you and everyone else. Personal safety first.
Always.
Then check for response. Gently shake the shoulders, ask loudly, are you all right? See if they react.
And if they don't respond.
Yep. Shout for help immediately. If you're alone, call the emergency services yourself. If others are around, direct someone specific to call. Don't delay getting help on the way.
Right. What if they're responsive?
If they're responsive, the immediate actions are different. Make them comfortable, try and figure out what's wrong, assess their vital signs, the usual initial assessment for a sick patient.
Okay, makes sense. But back to unresponsive. You've shouted for help. Next.
Check breathing. Open the airway, head tilt. Chin lift usually works. Then look, listen, and feel for normal breathing for no more than 10 seconds.
And importantly, ignore those gasps.
Yes, definitely ignore agonal breathing. Those occasional sharp gasps aren't effective breathing. If there's no normal breathing or only agonal breaths, you start CPR immediately.
Which brings us neatly to the ABCD approach, a structured way to manage things.
Exactly. So A is airway. We've opened it with head tilt chin lift. Check again for breathing. Maybe consider airway adjuncts like an oropharyngeal airway if you're trained and it's appropriate to help keep it open.
Okay, airway open. Then B, breathing.
Look for normal chest movement. As we said, if none or only agonal, move straight to C.
C is circulation, which means
Start chest compressions, that 30.2 ratio. Push hard, push fast. Aim for a rate of 100 to 120 compressions per minute.
and the depth.
Depth should be about 5 to 6 centimeters for an adult. And crucially, allow the chest to fully recoil between compressions. Let the heart fill back up.
Right, full recoil. Don't lean on the chest. Then D.
D is defibrillation. As soon as the defibrillator arrives, get the pads on. Minimize interruptions to CPR while you do this. Let the machine analyze the rhythm if it advises a shock.
Follow its instructions. Shock if indicated for VFET. Then immediately back to CPR for 2 minutes.
Exactly, and you repeat that cycle. CPR, rhythm analysis, shock if needed, more CPR.
So that rhythm analysis is the decision point each cycle.
It is. If it shows VF or pulseless VT, shockable, you follow that pathway. Shock, CPR. Consider drugs like adrenaline after the third shock, amiodarone if it persists.
And if it shows PEA or asystole, non-shockable.
Then no shock. Immediately resume CPR. Give adrenaline ASAP, as we discussed. And critically, you need to be thinking about why this is happening. You must search for and treat reversible causes.
Yes, the reversible causes. That's where the 4 H's and 4 T's come in, isn't it? Super important for PEA and asystole.
Absolutely vital. They are often the key to survival in non-shockable arrests. Shall we run through them?
Please do. The 4 H's first.
Okay. The 4 H's, hypoxia, lack of oxygen, hypovolemia, low blood volume, like from bleeding, hypothermia being too cold, and hyperkalemia, hypotassium. Though under that H, we also lump other metabolic issues like severe acidosis or hypoglycemia.
Okay, hypoxia, hypovolemia, hypothermia, hyperkalemia, metabolic, and the 4 T's.
The 4 T's. Tension pneumothorax, collapsed lung, putting pressure on the heart. Tamponade fluid buildup around the heart, squeezing it. Toxins overdose or poisoning. And thromboembolism could be a massive pulmonary embolism, clot in the lungs, or a coronary thrombosis, heart attack.
Tension pneumo, tamponade, toxins, thromboembolism. Got it. Any way to remember them easily.
You could think of the H's as things that hinder the heart's environment, lack of oxygen, volume, warmth, or the right chemistry. And the T's as things that physically tangle or stop the heart pressure, toxins, clots.
That's helpful. Hinder and tangle. And treating these is key for PE systole.
It's often the only way to get return of spontaneous circulation in those rhythms.
Beyond adrenaline and amiodarone, any other drugs briefly worth mentioning?
Well, the guidelines mention a few others for specific situations, though the main focus is CPR, defibrillation, adrenaline, amiodarone, and fixing reversible causes.
Okay.
You might give further amiodarone if VFET keeps recurring. Calcium chloride may be considered in PEA if you strongly suspect hyperkalemia or calcium channel blocker overdose. Magnesium sulfate for refractory VFET if you suspect low magnesium, perhaps in an alcoholic patient, for example. And sodium bicarbonate is really only for specific arrests. like known severe hyperkalemia or pricyclic antidepressant overdose, not routine.
So very specific indications for those latter ones.
Yes, definitely not first-line treatments in most cases.
Yeah.
Focus on the basics and the 4HS4Ts.
Okay, let's try and pull that all together. The absolute core takeaways. Rapidly identify the rhythm, shockable or non-shockable. Start high-quality CPR immediately with minimal interruptions. Defibrillate shockable rhythms, VFET, promptly. Give adrenaline at the right time, ASAP for non-shockable, after the third shock for shockable. Consider amiodarone for persistent VFET.
Yes, and crucially for PEA and asystole, aggressively search for and treat those reversible causes, the 4Hs and 4Ts, alongside the CPR and adrenaline.
That really seems to be the crux of it. Get the
Yeah.
basics right, follow the algorithm, and think about why, especially in P-systole.
Absolutely. Doing those things well early on makes a massive difference to outcomes.
This has been brilliant, really clear. Hopefully that breakdown helps anyone listening, particularly for MSRA prep. And speaking of prep, if you want more resources.
Definitely check out pastthemsra.com, and there's also freemsra.com for, well, free resources too. Both are excellent for targeted revision.
Great recommendations. So keep practicing these algorithms, embed those core principles, especially the difference between shockable and non-shockable pathways and those vital reversible causes. Thanks for tuning into the deep dive.